Okay, we're gonna return back to our educational program this morning. I hope you enjoyed your donut holes, maybe some caffeinated beverages. Hope you've been able to connect with your colleagues again and your peers. So we're gonna get started on the next part of our program. But before we do, just a few announcements. Please feel free to visit the Corrigian Cantina right outside of our exhibit space. Between 4 p.m. and 10 p.m. there'll be drinks for purchase there. Also, immediately after this session, we'll be having lunch served, combined with product theater sponsored by Regeneron at 12:30 and the Highland area where the combined meeting was yesterday. So I'll introduce our next speaker. Dr. Angela Kovacic is a board-certified general ophthalmologist, refractive cataract surgeon, and fellowship-trained neuro-ophthalmologist. She joined Horizon Eye Specialists and LASIK Center in 2015, but she graduated in honors from Arizona State University, where she double majored in chemistry and mathematics, earned her medical degree from Boston University, did her internship in Banner Good Samaritan in Phoenix. Then she completed her ophthalmology residency training at the University of Texas in San Antonio, where she earned Resident of the Year twice and elected a chief resident in her final year. She then completed a fellowship at the Neuro-Ophthalmology in Bascom Palmer, and she speaks Spanish. She also enjoys spending time with her husband and her kids, plays piano, draws, and she's excited to come to talk to us today. So please join me in welcoming Dr. Angela Kovacic.
Thank you, Dr. Winter, for that beautiful introduction. I'm honored to be here. Thank you for having me. So, as he said, I am what I would consider a comprehensive ophthalmologist. I do have the fellowship training in neuro-ophthalmology and do a lot of cataract and refractive surgery. So, I'm really excited to talk about kind of a combination of a neuro topic and a very hot topic that has been very dynamic over the course of the time I've been researching this. It seems like almost every couple months something else comes out. So you're getting kind of fresh, hot off the press kind of information. I have no financial disclosures pertaining to this lecture, but we'll be talking about the effects of GLP-1 receptor agonists on the eyes, essentially, and specifically kind of concentrating on the back of the eye and the optic nerve. So we're going to go over a short outline. I'll start with just sort of what is a GLP-1 receptor agonist, what's the mechanism of action, and then we'll go over some of the more studied conditions that are related to this, diabetic retinopathy, and then specifically the non-arteritic anterior ischemic optic neuropathy. We'll touch a little bit on IIH, which is idiopathic intracranial hypertension. That's what we used to know as pseudotumor cerebri, and then we'll wrap up. So what is a GLP-1 receptor agonist? Well, GLP stands for glucagon-like peptide, and it's an agonist, so it's going to stimulate the receptor. So it essentially acts to mimic glucagon. So in order to understand what that would do to us, we want to know what is glucagon and insulin and try to make sure that we have a good understanding of glucose homeostasis in our bloodstream. So glucose is going to be controlled in the bloodstream by sort of a teeter-totter or balance between insulin and glucagon. So insulin, we all know, is released in response to high blood sugar, so hyperglycemia, acts to lower the blood glucose and promotes glucose storage. So we're going to have glycogenesis in the liver storing the glucose. Whereas glucagon is going to be released in response to low blood sugar. So when there's hypoglycemia, your body will release glucagon to try to raise the blood sugar back up. And that's going to stimulate glucose production by breaking down the glycogen. So we'll go more in depth a little bit. We're not going to spend a ton of time on the mechanism, but I think it's important to understand that in order to understand why certain effects happen. So it's also important to remember that they stimulate, or they essentially stimulate each other. So if insulin is very high, then you're going to raise up the glucagon in response. So when glucagon is high, you'll raise up insulin. So that's sort of the backbone of why these are diabetic drugs, because if you mimic glucagon, then you'll raise insulin and help lower blood sugar. So glucagon itself is a molecule derived from a promolecule, so proglucagon. Proglucagon is in the pancreas, intestine, and brain. And when glucagon is around, it's going to stimulate, like I said, the breakdown of glycogen, not only from the liver, but it's also going to try to form glucose from non-carbohydrate substances, and that's gluconeogenesis. So that's when you start breaking down muscle, protein, and fat to create more glucose. So you can kind of think about a GLP-1 receptor or glucagon as when your body needs energy, but energy is scarce, so food is scarce. So you need to form glucose by not getting it in your diet, but by making it in your body. And that's sort of the whole backbone, again, why these work so well, to lower weight and to control sugars. So it's also going to reduce the appetite and food intake, and we'll talk about that in the next slide as well. So actually, in another slide. But this one goes over two other hormones, or the GLP-1, and it's sort of like friend or a sister, GIP. So GIP is the glucose-dependent insulinotropic polypeptide. This was the first incretin peptide that was isolated, and it also has the name gastric inhibitory polypeptide. So basically what they found was that hormone, when it was released, it did increase the secretion of insulin, and so it helped control blood sugar. But when they started looking at that in humans, it didn't seem to work as well for diabetics because they had impaired insulin secretion. So GLP-1 was later cloned. It showed a greater glucose-dependent insulin secretion, and it maintained that action in type 2 diabetic patients. So they were still able to produce and secrete their insulin in response to the medicine. So this ultimately led to more clinical development of GLP-1 receptor agonists. We'll see later that there are some on the market that are now a combination of these two. So the GLP-1 receptors live really all over the body, but primarily they exist in our brain, our intestines, and the pancreas. So at the brain level, when the receptor is stimulated, it's going to promote the feeling of satiety, reducing your appetite. So this is why you can lose weight. At the gut level, it's going to slow down gastric emptying of the stomach, so you have a prolonged feeling of fullness. So those two things in combination are what really can restrict the calories and cause the weight loss. And then at the pancreatic level, like we talked about in the other slide, it's going to reduce the release of glucagon, because when you have what looks like glucagon in the system, your pancreas isn't going to want to produce more, and it will actually increase the insulin secretion, which will further reduce sugar control. So great for diabetes, great for weight loss. But as you can probably already tell, it's going to potentially have the most GI side effects, because you slow down gastric emptying, you'll have that feeling of nausea or uncomfortable, bloating, things like that, that people who may be on those have experienced or you've heard from patients. So GLP-1 receptor therapies have sort of blown up. They've turned from a really niche diabetic treatment back in 2005 when the first one was put on the market. So they've been out actually for over 10 years. To a mainstream chronic therapy for all sorts of things now. Still type 2 diabetes and obesity being the most common, but cardiovascular risk reduction, renal protection, neuroprotection, the list goes on and on. So as this prescribing volume is increasing, we are going to be seeing a lot more patients who are taking these medications. And you will need to start reminding your staff to ask about them in their medical histories, make sure that that's part of what they're always asking. Not only in a pre-op for surgery, which we can touch on later why that would be important, but especially when we're talking about an ocular event. So the practical question is, how are we interpreting an ocular event that happens while someone is on a GLP-1 receptor therapy? So that's what we'll try to attempt to answer today. This is just a slide to remind you about all the different ones that are on the market. So sometimes you see a med on this list on their medical history, and it doesn't necessarily immediately trigger in your mind that that's a GLP-1 receptor agonist. But all of these are, Byetta, exenatide being the first one that was released in 2005. There's so many, partly because there's some of them are FDA approved just for diabetes. Some are on label for obesity only, some of them are subcutaneous, some of them are oral. So any of those names you want to remember is a GLP-1. The last one, tirzepatide, being the one that's the combination. So that's the GLP-1 receptor and GIP receptor agonist combo. So how do they affect the eye? And that's what we're going to try to attempt to kind of understand more today, which the short answer is we don't know, but we're going to go over more. So is it some kind of direct ocular toxic effect? That's something we always need to think about when any new medication starts gaining traction. Is it a secondary vascular effect, which we'll look at that later too. Just the rapid metabolic change with all that insulin being secreted and the blood sugar dropping so rapidly. A lot of patients get a rapid reduction in their hemoglobin A1C. With the rapid weight loss combination, they can really change their metabolic status quickly. Or is it just their underlying disease burden that's causing these ocular events and has nothing to do with the medication? So we're going to go over mostly, like I said before, diabetic retinopathy and non-arteritic anterior ischemic optic neuropathy. But there are studies and case reports starting to pop up every couple months, so to speak, on macular degeneration, on cataracts, on glaucoma, on dry eye. And it's like the magic drug. But then there's always the counter of, is it worse? Is it making macular degeneration worse or glaucoma? Seems to be we just don't know. It might be protective in cataract, but we don't know really about a lot of the other ones, so I won't really spend a lot of time on them. And then idiopathic intracranial hypertension I have lower down because it's not so much that we're looking at it as an effect of the med, but as a potential treatment. So to put this in context of prevalence of some of these conditions that we're talking about, we're just a blip on the radar. This chart doesn't show AMD, but if you look at the first bar, that's our more or less the prevalence of diabetes, that over 10% of the population is living with diabetes in the US, over 38 million adults. Macular degeneration is about 20 million now. Glaucoma, 4 to 6-ish, depending on what you're reading. And so that's maybe 2 to 3% of the population living with glaucoma, whereas people who have NAION, there's only about 16,000 at any given time. So that's 0.02% of the population, and then 0.009% of the people with papilledema from IIH. So we are kind of talking about a small scale, but we're also talking about real risks. So we'll talk about those as we move on. So we're going to switch over now to diabetic retinopathy. So as most of you know, diabetic retinopathy is a microvascular complication of diabetes that happens to the retinal arterioles, resulting in microaneurysms, dot blot hemorrhages, exudate formation. You may get macular edema, proliferative changes. I know you've heard a lot about retina today, and so this is something that some of you may have already been noticing with all these GLP-1 therapies on the market, that you might be seeing more diabetic retinopathy. And what we already know to be true from even the late 90s is that there is early worsening of diabetic retinopathy in rapid glucose control. So that's a known phenomenon. So it's an easy jump to think that the diabetic retinopathy worsening we're seeing with GLP-1s is a result of rapid blood sugar control. In the SUSTAIN 6 study, which was one of the largest ones in 2016, that was really well done, randomized, double-blind controlled, so all of the gold standard of a study. They had over 3,000 patients, all with type 2 diabetes, and their primary endpoint was not related to the eyes. So they were looking at cardiovascular death, non-fatal MI, things like that. But they did have a secondary endpoint with diabetic retinopathy. And what they found was that in patients taking semaglutide versus the patients who were not, that they had about a 2% or a 2 times risk of developing worsening of their diabetic retinopathy. So it wasn't a primary endpoint. It wasn't really well controlled as far as what they called worsening. Any new microaneurysm might have been considered it, and in another, it might have been a vitreous hemorrhage that was new. So it's one of those things we don't fully know, but it's probably around that hazard ratio. So remember, a hazard ratio means that if a hazard ratio of 1.0 means there's no difference between the study and the placebo or the non-drug. Anything less than 1 would mean it's protective, and anything over 1 would mean there's an increased risk. So 1.76 times risk. Since then, there's been more meta-analyses that have come out, meta-regression studies that show us the similar results, that the greater hemoglobin A1C reduction correlated with the higher retinopathy risk. And that's usually within 6 months of starting the drug. So that's going to be another reason why it's really important to get good medical histories. When did you start it? What dose are you on? Did you recently change your dose? And have a good documentation of their baseline retinopathy status, ideally before they start a therapy like that. But because we know so much about diabetic retinopathy and its effects with reduction of blood sugar and A1C, we think this is probably not a direct retinal toxic effect from the therapy, but it is just related to the drug, just related to the metabolic shift. And so you would just treat according to standard of care. There's really no recommendation to stop the therapy at this time. However, the FDA has included labeling on their US packaging for GLP-1 agonists that tell the patients to make sure that they are being screened. So semaglutide, tirzepatide, and dulaglutide all have that US labeling saying diabetic retinopathy monitoring in patients with history of diabetes, diabetic retinopathy. So in theory, a diabetic who doesn't have any retinopathy doesn't have to worry as much, but of course they should all be screened. Liraglutide, exenatide, and lixisenatide don't have that label yet. So we're going to switch gears now and spend a little bit more time with the neuro part of the talk, the non-arteritic anterior ischemic optic neuropathy risk. So NAION is the most common acute optic neuropathy in adults over the age of 50. As most of you know, this results in a painless monocular vision loss with usually an altitudinal field defect. The nerve oftentimes looks swollen, like you can see in the picture here. A lot of times you do see hemorrhages, flame hemorrhages around. It may only be segmentally swollen, but it's usually not pale. The risk factors would be things like anatomical crowding of the optic disc, so someone with a small cup-to-disc ratio to begin with, male gender, hypertension, and honestly hypotension should probably be on there as well, diabetes, hypercoagulability states, obstructive sleep apnea, among others. So really a lot of factors contribute to someone having a risk for NAION, and we're kind of uncovering more and more every couple of years. And so as I just gave you that list and we know about the types of patients who take GLP-1s, you can see there's a lot of overlap. Patients on a GLP-1 therapy at baseline already carry very similar risks to someone who might be at high risk to get an NAION. So that goes back to our other question, is it just disease burden? And it really has nothing to do with the drug. And so for many years, we didn't really notice much and didn't really necessarily warn patients until 2 years ago in 2024, when Hathaway published a really kind of eye-opening study on the risk of semaglutide and non-arteritic anterior ischemic optic neuropathy. So they had a retrospective study, because NAION is a really hard endpoint to have be prospective, but they had 17,000 patients that they reviewed over the course of 6 years. They looked at a 36-month endpoint. So at any point where they were reviewing the chart, they looked for any NAION episode that was documented in the next 3 years of them starting the medication. All of their patients were diabetic, and then they re-stratified them into type 2 diabetes only, or the people who were overweight and obese. So you can see there the breakdown of how many patients and how many patients experienced an event. And what we found was, or what they found was pretty shocking. In the type 2 diabetes group, they had 9% of them developed an NAION in the 3 years that they followed them, versus 1.8% in the patients who were not taking semaglutide. And that equated to a hazard ratio of over 4. So that's a really big risk. And then in their overweight obese strata, they had 6.7% of their patients develop an NAION out of the 0.8 who were not on semaglutide, which was a 7.6 hazard ratio. So huge risk that really raised a lot of questions about the safety of this class of drugs, specifically semaglutide. So we didn't know if this is real or not. It was retrospective match cohort, is a real risk. So that more studies are coming out. The next one we're going to touch on was published the following year, so last year in 25, another retrospective cohort, like I was saying. But in this case, we had a lot more patients. So 3 million patients, all diabetic, all on semaglutide versus a non-GLP-1 receptor agonist therapy for management of their diabetes. So this one did not stratify obese patients out, but they monitored them at more increments. So we have a 1 month, 3 month, 6 month, 1 year, and you can see the black line on these charts are the semaglutide group. The red line are the patients who are not on GLP-1 receptor agonist therapy. And you can see a trend toward higher risk of NAION, but if you look carefully, I know it's hard to see, but the p-values are not significant in any of these time points. They continued to follow them to 4 years, and at 2 years, that p-value you can see dropped. So at 2, 3, and 4, and over the course of the study, the risk of developing an NAION in the patients on semaglutide was twice that of the patients who were not. So they got a hazard ratio closer to 2. 2.3 at 2 years, 2.4, and 2.0. So now we're getting a little more comfortable that maybe the risk is not 4 or 7, but it might be 2, just still potentially very significant. The year before that, there was a big Danish nationwide cohort that got published. This was also longitudinal, retrospective, again, only type 2 diabetic patients and only those on semaglutide. So far, semaglutide is sort of like leading the pack with the studies, and we don't necessarily know if that's generalizable to all the GLP-1s, but they found, again, a hazard ratio over the 400,000 patients that they reviewed of about 2 in their 5-year review. So really, we need more studies, like we do with everything, basically, but recently published a few months ago online available in ophthalmology was a meta-analysis of the 6 largest studies that are out right now about diabetes and diabetes on semaglutide with NAION. And they actually found that there was almost no difference. So we really don't know, but we do have some evidence to suggest that there might be up to a 2% or 2 times risk of developing NAION. So these patients, it's real. And because it is not something that's very easily treatable and usually not curative, the vision loss is almost always permanent, it's an important thing to really be looking at. As I said before, there's no randomized trial that has NAION as a primary endpoint. We probably won't get those, so we just basically have to just keep relying on retrospective type of reviews. So why would somebody on a GLP-1 get an NAION? So first we need to kind of understand, why do people get NAION, period? We know the risks, but pathophysiologically, why does it happen? And unfortunately, we don't know that either. That's been a question for our neuro-ophthalmology community for decades. The pathogenesis is not entirely understood, but the prevailing theory, as most of you might already kind of know, is that we think there's a transient drop in perfusion pressure to the optic nerve head, and this causes a axoplasmic stasis and then edema in a confined space, which would be the scleral canal in this case, causing what would be like a compartment syndrome, but of the nerve. So you get that cell death, you get the swelling, and there's really no way to decompress that area surgically. There's no way to really reduce the swelling effectively. So we don't have a good treatment. You probably all learned at some point in training about the use of steroids, and yes or no. A lot of studies and meta-analyses on that are still not clear. Whether you use steroids or don't, I think most of us don't anymore, but it's one of those things we don't know. The association with something like a PDE5, that's a phosphodiesterase inhibitor, like Viagra or Cialis, or even amiodarone, which we know amiodarone can affect the optic nerve, but usually not in the same way that a traditional NAION. So that's more of a, we don't know, optic neuropathy, optic neuritis, toxicity. But we do know that the FDA has put out labels on those drugs. So we know in Cialis and Viagra packaging, they do have a specific, not just blurred vision, talk to your provider, but sudden vision loss in one or both eyes, and then they specifically call out NAION. And they even go so far as to say that a patient with a crowded disc may be at increased risk. So it is a real risk, and most of the neuro people in the world are asking about this, but I'm sure the general ophthalmologists are thinking about that too when you see an NAION. And that is actually, to me at least, an indication to stop it. I'm never going to necessarily tell a patient what to do, but it's like a enter at your own risk. If you really need that medicine and you are okay with going blind, by all means, but it's probably not the risk-benefit ratio I want to take. The other medicine is not so easy to just say stop taking it. That's amiodarone. That would be, and so the FDA warnings are showing blurred vision and optic neuropathy. Talk to your doctor essentially. They call out corneal microdeposits, which those are the verticillata that we see when patients are on that drug. They're usually visually insignificant. They are almost always reversible if the patient stops. But if they develop an optic neuropathy on amiodarone, I'm usually on the phone with their cardiologist or their prescribing provider, asking them to reduce the dose or stop it, or transition them to something else, because that vision loss would be permanent, similar to NAION. So the FDA is on board with some warnings with this, but we have no labeling for NAION on the GLP-1s yet. So sort of like the jury's out in that sense. Once we probably get a little more information, I'm sure those warnings will pop up because the diabetic retinopathy ones came out. But getting more onto why is this happening, we still don't really know. But there are GLP-1 receptors on the optic nerve, and so we don't know whether or not continuous stimulation is doing anything to them. Is it causing the nerve to swell? Is it causing vascular permeability problems or perfusion? The GLP-1s, as I said before, offer weight loss as a side effect, which weight loss independently can lower blood pressure. So one theory is if the blood pressure is lower and the patient is not correspondingly decreased on their blood pressure medication, that they could have a hypotensive event, just like we know a traditional NAION patient shouldn't take their blood pressure meds at night necessarily, or should be talking to their cardiologist to not drop, because hypotensive events are one of the risks for these events. So whether it's that, whether it's the vascular permeability. So one of the other theories would be that when you have so much insulin being secreted, you get a lower concentration of glucose in the bloodstream. And that's going to cause an osmotic effect where the inside of the blood vessel has a lower osmolarity than outside, and that could cause water from the interstitial space to move into the blood vessel and then cause it to expand and leak. That would be the theory that is potentially behind diabetic retinopathy. So is that happening at the optic nerve head? We don't know, but they're all just like food for thought theories. When do you stop it? We don't really have any strong recommendations yet, but our NANOS community, so the North American Neuro-Ophthalmology Society, put out a statement that saying that the proposed risk of NAION is still much lower than the overall health risk to someone who needs semaglutide. So if you're currently taking semaglutide, they do not recommend stopping it without consulting your prescribing doctor. Their statement really had nothing to do specifically with whether or not they were diagnosed with NAION. But you may already start getting questions. I certainly am, of patients who are on them and they heard about this and they want to know, should I stop it? Am I at risk for a stroke to my eye? Right now, at least what we know, they don't really need to stop it unless an event is confirmed. Then you might want to be thinking more, especially if what they're on is semaglutide specifically. The European Medical Agency did actually put out a statement that says that if NAION is confirmed, they do recommend you stop semaglutide treatment. So again, that's only specific to semaglutide, and that's in Europe, but it is one of those things that it's definitely on the radar. So I think as a kind of take home on the NAION, I would screen all patients, and this is what I do right now, who are on a GLP-1 receptor agonist, especially those on semaglutide, for a crowded disc. If they have one, I tell them they have a risk for an NAION, which actually I tell all patients who have crowded discs, and we go over some risk factors about that, but it would be specifically in these kind of like hit it harder. I do a baseline RNFL on all patients on a GLP-1. I don't bill for it, but I like to have a baseline. It's something I would consider. Advise patients who are at higher risk for NAION at baseline, like obese, hyperlipidemia, obstructive sleep apnea, to make sure that they are monitoring their blood pressure while they're losing their weight and getting their diabetes under control or whatever they're on it for, and make sure that they're talking about their blood pressure medications with their provider. And then I would discuss with their prescribing provider, if the NAION was confirmed, to potentially stop the drug. At this point, we really have no evidence on dose dependence. So we don't know whether or not lowering the dose is protective or advised. I've had a few patients who've had an event now on a GLP-1 who otherwise were not at significant risk, and their prescribing doctors have asked me, can they stay on it and I'll just lower the dose? And I mean, I really don't know. So all I can tell them is, there's a risk, and the patients I've seen so far have not been diabetic. So we think that probably there is an increased risk in the general population, but we don't have studies to show that. So that's the NAION piece. And then we're just going to switch gears just for a few minutes on the idiopathic intracranial hypertension. So IIH, which again used to be pseudotumor cerebri, syndrome of raised intracranial pressure without another structural cause. So these are people that have high cerebrospinal fluid pressures. We don't know why. There's not an obstruction. There's not a blood clot. The risk of this is female sex, obesity, or someone who's had a rapid weight gain. And then it's going to result in papilledema, so bilateral disc swelling. Transient vision loss, diplopia, headache, pulsatile tinnitus are usually the things that the patient's going to advocate. The mainstay of treatment is diuresis, so we want to lower the CSF pressure. Usually we use acetazolamide or Diamox. Less frequently, things like topiramate, furosemide, spironolactone. And then the biggest one on top of the medication part is weight loss. So it's been really well proven and studied that weight loss is an independent improvement in cerebrospinal fluid pressure, so ICP. Even 10% of a patient's weight can significantly reduce their ICP. So patients who are like 300 pounds, let's say, they only need to necessarily lose 30 pounds and they could potentially start curbing their disease. So a lot of times it's very daunting to these patients to be told your disease is because you're overweight and you have to lose weight or you're going to go blind. Realistically, they don't have to get to ideal body weight. They just need to start changing their life and changing some of their habits. And ultimately, we don't know completely why there are patients who are obese and never get it, and there are other patients who are only moderately overweight and do get it. So with regards to GLP-1 receptor therapy, it can help reduce weight, like we talked about, reduce appetite, prolonged feeling of fullness, all those things. So that alone will help them lower their ICP. But more studies are coming out now that show that the GLP-1 receptors might independently lower ICP by their action in the brain. So we know that GLP-1 receptors are expressed in the choroid plexus. That's a part of the brain that makes the CSF. And that when you stimulate them, you can actually lower the production of ICP. So in 2023, we had a nice study come out with 16 women randomized controlled on exenatide, which was one of those early ones, the GLP-1s, versus placebo. They were able to do transdermal telemetric ICP monitoring, so they didn't have to do anything invasive. And they watched them after 2.5 hours, and then 24 hours, and then 12 weeks later. And even at 2.5 hours, they had a reduction of 5 centimeters of CSF pressure reduction that was significant. So the p-value was less than 0.05. And then it maintained that at 24 and at 12 weeks. So their ICP was significantly reduced, which was great. Their weight wasn't measured, but their headaches trended towards improvement, and then their visual acuity improved as well. So that was kind of a really nice way of proving that this could be a good therapy. And then in 2025, last year, we had another study come out, and a bigger one, a retrospective cohort, but in this case, they were tirzepatide patients. So instead of exenatide, tirzepatide is the one that has the combo, the GIP and the GLP-1 receptor, and they were also able to show a reduction in risk across all parameters. So this is kind of a busy slide, but that says papilledema on the left, headache, refractory IIH, and visual disturbances or blindness. And if you look at that risk ratio column in the middle, they're all less than 1. If you look at the p-values on the end, they're not all significant, but the papilledema group, they are, and the visual disturbances category, they are. So they did significantly reduce the papilledema on patients on tirzepatide. So does that mean they all need to be on it? Maybe, maybe not, we don't know. But to kind of play devil's advocate, the concern regarding really any time someone's on a GLP-1 receptor agonist is getting off. And so there are new studies now and case reports coming out that when a patient does drop weight with IIH from a GLP-1 receptor agonist help, they can get a more refractory case when they stop it. So that does give us a little bit of pause about how we're dosing, how we need to start tapering them off, because when you get off of it, you can get a rebound, weight gain, and sometimes that increase in your sugar again. So we know there's a lot of things at play. So the promising results overall, more studies needed, kind of like the theme of this talk. But I wanted to just touch quickly on the fact that both IIH and NAION present with a swollen disc. So that's one of those things that you need to sort of parse out, like why would NAION, swollen disc, be so dangerous for a GLP-1 receptor agonist and papilledema, swollen disc not? I don't have an answer to that question. Obviously, we know the pathophysiology of a swollen optic nerve in papilledema is different because we have ICP in the optic nerve sheath behind the eye, pushing the nerve forward, so to speak. So it's not really a direct vascular effect, but the GLP-1 receptors help to improve vision, whereas a GLP-1 receptor in NAION, in theory, is what caused it. So does that same risk apply? And then what about in concurrent optic nerve head drusen? So I'm just putting those out there more for food for thought. There's no studies yet, but optic nerve head drusen would be an independent risk for NAION by itself. And so those patients, are you going to be even more cautious about recommending it? Or if they're already on it, having them talk to their provider about that? All good questions, but without answers. And then we'll just kind of wrap up here. So our take-home points, I would say ask every symptomatic patient or even non-symptomatic patient, but if they're taking a GLP-1 receptor agonist, which one and why? When was it started, and was the dose recently increased? Even though we don't have good studies on dose dependence, I think we will start seeing that, and it's good to document that. If an NAION is suspected, you want to coordinate with the prescribing physician, and specifically if it was semaglutide they were on, I would consider discontinuation. If you see a worsening diabetic retinopathy patient, you would want to make sure you're documenting baseline severity and how it changed. Ask about their speed of their A1C control, and then treat like you would per the standard of care with retina. Refer as needed and treat them, but don't discontinue the medication. And then the last point, just to consider adding a GLP-1 receptor or a combo GLP-1 to IIH treatment. These are my references, and I thank you for your attention, and I'll ask for any questions you might have. Yes? It's really only used in studies. It's not really clinically relevant right now, yeah. No. I would be great, but yes.
Wonderful presentation.
Thank you.
I'm just a first-year medical student, so there's still a lot for me to learn.
Yeah.
But from my understanding, when you have an NAION, there's an increased risk for a brain stroke. But when you're taking GLP, it reduces the risk. Is there any study that shows that even when you're on GLP, once you have an NAION, there's still an increased risk for a brain stroke?
There are no studies like that, but NAION really is not an increased risk for cerebral attack like that. Something that would be arteritic would be. So arteritic ischemic optic neuropathy, which is the one that you'll learn is temporal arteritis or giant cell arteritis, that one has that increased risk of other stroke. NAION is sort of this weird beast that we don't totally understand, but it doesn't actually confer the same risk. So we wouldn't necessarily even, at one point we were putting them on aspirin. It's one of those things where it's not even really that recommended at this point. So that is a good question and something to look at too, just in general for the GLP-1s. But yeah, unfortunately, we don't have studies about that. Any other comments or questions? Well, thank you for your attention. I appreciate it.
Thank you, Angela, for that presentation. She will be around maybe a little longer. I told her you guys were probably going to bombard her with questions about neuro, but be nice. So we'll go ahead and we're a few minutes early, so we'll go ahead and introduce our next speaker. Dr. Jonathan Holmes completed undergraduate studies at Cambridge University and medical school at Oxford University. He was an ophthalmology resident at Loyola University Chicago and fellow in pediatric ophthalmology and strabismus at the University of Michigan. He worked for 25 years at Mayo Clinic Rochester, becoming the chair of ophthalmology from 2001 to 2009, and the Joseph E. and Rose Marie Green Professor in 2009. Dr. Holmes moved to the University of Arizona Tucson in 2020, and he's been a professor and chair of ophthalmology there since. He has been one of the leaders in the PDIG, the Pediatric Eye Disease Investigator Treatment Group, for over 29 years, directing multi-center randomized controlled clinical trials and observational studies, and his surgical practice is focused on complex strabismus. Please welcome to the stage Dr. Jonathan Holmes.
Well, thank you so much. It's a great pleasure to be here. Thank you very much for the organizing committee for inviting me to present to you today. So I'm going to give you a couple of talks. The first one's going to be kind of a general talk about why do we worry about strabismus in adults? Isn't it a childhood problem that we don't have to worry about? So I have no financial interests. I just have some funding from the NIH. So why do we treat adults with strabismus? And at a high level, because strabismus really messes you up as an adult. And we're going to get into that as to how it messes you up. And the way we're going to approach that this morning is we're going to go back to this famous report by the Institute of Medicine called Crossing the Quality Chiasm. And one aspect of this report highlighted the need to make patient care patient-centric. And so how do we make healthcare patient-centric? Well, we have to listen to the patient. And I have this expression with my residents and fellows, which is that the patient is always right. Well, 99% of the time, the patient is always right. But the patients come to us with concerns, complaints, worries, things that bother them. And it's our job as providers to find solutions to those problems. And so as we approach the whole area of why do we treat certain conditions, I think it's very helpful to ask the patients what bothers them about their condition and how it affects their everyday lives. And that leads us into this world of patient-reported outcome measures. This is a quote, and you can think about it yourself, which is, how do you feel about patient-reported outcome measures? And this is a quote from the BMJ, that clinicians are often reluctant to use patient-reported outcome measures because they feel it will add to their workload rather than make them more efficient and more effective. And so this is another parallel thought or problem that we have to grapple with, which is how are we going to incorporate patient-reported outcome measures maybe into our practice? The alternative perspective, and this goes way back to Lord Kelvin, if you can't measure it or quantify it, then you can't study it. So it applies both to research and then to your individual patient encounters. So patient-reported outcome measures can assess various aspects of the patient's perspective, what bothers the patient, how it affects their lives. It also gets into what they can and can't do, and we can call that functional vision, and it gets into symptoms. And one of the challenges with current patient-reported outcome measures is that they assess some of these, all of these, part of these, but often they mix them up. And then you end up getting these hybrid things which are very difficult to interpret. So how do we get to a validated patient-reported outcome measure? And the reason I've made this sort of generic is that whether you're a retinal surgeon or a cataract surgeon or a glaucoma surgeon, you can be thinking about how you might apply patient-reported outcome measures in your own practices. And one of my big appeals is that we can't just make something up, and I call this the tyranny of the experts, so which is that physicians get together typically in a room in an airport because people fly into these types of things, and then they just say, well, what bothers your patients, what bothers your patients, and they just make up a list of items, and that's the wrong way to start. Many of the existing quality of life measures are made up that way. So this results in just a few amusing anecdotes in terms of things not to do. So I was in Rochester, Minnesota for a lot of my career, and there's one questionnaire that's used a lot, and one of the questions is, I have difficulty finding my way in a train station because of my vision. The problem with that in Rochester, Minnesota, there are no train stations in Rochester, Minnesota. So the person who lives and breathes life in Rochester, Minnesota can't even answer this question because they don't even go to the train station. Another questionnaire has this question, which is, I have difficulties riding my bicycle because of my vision. And I've, on one side of the slide here on the left, I showed you a typical parking lot in the Netherlands. And we know what a typical parking lot looks like in the US. And so unless you're an avid recreational biker, difficulties riding your bike might not be relevant to you. Another final example is, I have difficulties playing ball games because of my vision, but actually your hobby is chess and you actually never play ball games. So these are all examples of how existing quality of life metrics actually become not very usable for many patients. So then we go back and say, well, okay, in the world of strabismus, and you can think of this in the world of retina, in the world of cataracts, in the world of glaucoma, what bothers, troubles, upsets, annoys adults with strabismus? So what we did a number of years ago is that we actually just interviewed a bunch of patients. And we try to cover many types of strabismus, those associated with double vision, those associated not with double vision, mechanical causes, some that started in childhood, and other neurogenic causes. And we just went through and we asked them open-ended questions. And then we just let the tape recorder run. And they all consented to this with the understanding that we were going to take those transcripts and then take individual quotes from those transcripts to actually design our first questionnaire. So here's a typical patient with a large, and we'll come back to this particular patient in a few minutes, as a large angle exotropia. And these are the sorts of quotes that came up in these open-ended interviews. People don't want to give you an opportunity because they see something different about you. It kind of scares people off. They think you're on drugs. It's kind of hard to find a new job because of the one-on-one eye contact that's needed. Sometimes people don't want to talk to you because of your eyes. They look at you like you're awkward, like you're different. They don't want to give you respect. You're a deformed person. These are the direct quotes that come from patients with strabismus. So we group these into groups, and there are clearly concerns about patients' appearance, about eye contact, about interpersonal relationships, and about how they view themselves. Those are without diplopia. Patients who have diplopia, you would think that they would actually focus on the double vision and what they can't do. But actually what was interesting is that there were a lot of non-specific negative feelings, like it's really hard, it's miserable, it's emotionally draining. And there's this feeling of general disability, that it affects everything, that they feel handicapped. Clearly it affects driving, and clearly it affects self-esteem. So these tended to group in two main areas, the psychosocial area and the function area. Let's just say a word about diplopia. Sadly, perhaps many of you in the room are really kind of uncomfortable with the symptom of diplopia, and you can't wait to refer it to your colleague and get it out of your office. In fact, this quote just sort of caused me to pause. A recent colleague said to me, "The patient has to complain at least 3 times about double before I pay any attention." I think that's sort of an indictment to us all, is that, again, the patient is always right. It's not their fault that their main concern is double, and so we have to at least refer that patient. So how do we characterize and quantify double vision? Well, the most important gaze positions are distance straight ahead. That's how people drive. They watch the TV. And then near, specifically, reading. And we need to collect data on those specifically, those positions. You can use history. You can use standardized measures. And the one thing that's kind of gone out of vogue and was certainly more in vogue 20, 30 years ago was to put the patient on the Goldman visual field with both eyes open and plot a field of single binocular vision, and this can be scored, and you can give you a score out of 10, out of 100. What we did a number of years ago is we actually developed this form, and we've made it publicly available, and we've put most of our stuff on the PEDIG website, not because it's pediatrics, but because that's a website that's public that I can get access to, being a PEDIG investigator and a leader. But you can download this, and I hand this to my patients every time they visit me, and I have the front desk just hand it out. And it asks them, in the past week, do you have double vision in reading position? Always, often, sometimes, rarely, never. Looking straight ahead in the distance, looking up, looking down, looking right, looking left, and in any other position. And very quickly, when I get this form, and it takes all of a minute for the patient to fill this out, I can see at a glance what the patient's problem is, basically. And we have devised scoring methods. So in the research environment, we can, by weighting it towards distance straight ahead and reading, we can give it a score that's weighted there. But probably more importantly, in the clinic, you can actually just see at a glance, okay, this patient's just got reading problems, or this patient doesn't have reading problems at all, but it's mostly in the distance. It's a very easy thing to fill out. So let's just drill down on one patient. This was a patient who had surgery as a child, as an infant, had esotropia as an infant, and had surgery. At the age of 2, had a right R&R. Was initially overcorrected, but not so much so that went back to surgery, but he kind of grew up with an increasing amount of exotropia. And he presented to me as a 33-year-old adult. He had no diplopia because he was suppressing. And that's the typical story of the adult who had childhood strabismus. Typically, they suppress, although some of them will have intermittent diplopia. And his primary concern was that people don't know that he's looking at them when he's talking to them. He's looking to the side, are you looking at me? And we've all seen patients like this. One of our biggest challenges is that there's a lot of misinformation out there, which is that these types of patients are often told nothing can be done, or nothing should be done. And so for those of you who aren't in this business, one of my sort of take-home messages from this talk is that stuff can be done, and you should be referring them to your colleagues who do deal with it. This gentleman had a very large angular exotropia. He had a lag of adduction of the left eye, but of the right eye, he could barely get that to midline, and it certainly was suspicious for either a lost muscle or a slip muscle or a very attenuated insertion. And the rest of the exam was normal. He had the expected slightly more hyperopia in the right eye. Interestingly, he didn't have much amblyopia because he was actually successfully treated as a child. And many of these people have good vision. But whether they have good vision or not, psychosocially, this really affected them. So we went in there, we found the muscle that was not attached to the globe, and we reattached it, did lateral rectus recessions, and did all that on adjustable sutures so we could set him with the desired micro esotropia. But one of the reasons, and this is one of the take-home messages, is that why is it that many of our colleagues, and perhaps some of you in the room, kind of warn patients off these types of surgeries, and it's primarily a fear of inducing diplopia. So you've got a patient he's 33, young guy, he's got a large angle XT, he's not having diplopia, but you worry about when you straighten the eyes, will he get diplopia? And it's one of the reasons, probably the main reason, that people are deprived of surgery. So Bert Kushner, 2.5 decades ago, wrote up his series of over 400 patients, and he routinely held up Prism and asked them, do you see double? And I think this is where most people get hung up on that, because maybe you do hold up Prism and you ask the patient, well, do you see double? And they go, oh yeah, no, I see double now. And it stops there, right? Because they say, well, that may be what you're going to experience. And indeed, Bert Kushner described that about a third of the patients did experience double in the office. But the most important thing is that after surgery, first point, if they didn't show double, it's a very good prognostic sign that they won't get double. So in other words, if they continue to suppress with the prism there, then you're in the 2/3 that are probably going to do very well with surgery and they can go on. But the kicker is what happens to those who had double when you held up the prism? And the answer is that 9–10% of them did have temporary double vision afterwards. And I use it as a teachable moment for the patient, which is you are going to have some double when you wake up from surgery, but less than 1% had intractable double vision. Because the patient's visual system is plastic enough that it can readapt to that. Now, you do have to tell them there's maybe a 1% chance that you'll be that and then you have to, as a patient, weigh up. Do you want the 99% chance that you're not going to get bad double or the 1% chance? And every patient has to make their own decision, but it's our job to present that information to the patient. So that's the message I give to these patients, is that even if they're seeing double, particularly if they're seeing double, then I say, this is what you're going to experience. And I explain, you're not going to be able to drive between 1 and 8 weeks after surgery. And that sometimes is a deal breaker for the odd patient who that's going to be a real problem. At least they have that information. But only 1% of them are going to have long-standing diplopia. And we followed this up with using our questionnaire, and we found very similar for constant double. A little higher for temporary. What's interesting with these patients is that they do not ask, if they're in the 1%, they don't ask to be reversed, because the benefit that they achieve, I mean, never say never in medicine, but the vast majority of them do not want to be reversed, even if they are in the 1%, because the benefit they achieve in terms of their socialization and the interactions and their self-esteem is such a great improvement that they don't do that. So that then leads to, well, can we put a number on that? I'm talked about anecdotes. So what we did is we took those interviews I talked about, and we went through the process of transcribing them and then converting it into a master questionnaire, which had 181 items. And then we had 29 unfortunate patients who sat through very long answering that. And then we analyzed those and basically got rid of the questions or the items that had floor and ceiling effects. And then we realized that they segregated into psychosocial and into function, and then we basically took the top 10 psychosocial questions and the top 10 function questions. And we had deliberately avoided, so we didn't want to be guilty of what I just presented to you at the beginning, which are the questions that don't apply. So we avoided questions about train stations. We avoided questions about bicycles. We avoided questions about ball games. And even the seemingly obvious, which actually many of my patients, when I was in Minnesota, they used to drive to me from the Dakotas, and everyone drives. But we remembered that if we wanted this questionnaire to be useful, some people practice in New York City or practice in Tokyo, and only a fraction of people bother to have a car there. So there's such great public transportation in these big cities that they don't use a car. So if you have questions that are focused on driving, then it doesn't get to every patient. So there were two clusters, psychosocial and function. And then, so this then becomes the AS20 questionnaire, or the Adult Strabismus 20. First 10 questions are psychosocial issues, about whether it bothers them the way that people interact with them. And again, we've made these available on the PDIG website so you can access them and pull them off and use them. And 20 questions, and then the next 10 questions are on function in terms of reading and doing hobbies and that sort of thing. We initially scored it on a flat scale, and we learned a lot about how to score questionnaires. And there are scoring grids. You can either use it informally. Again, I deliver this to every patient that comes into my clinic, an adult strabismus patient, and I can tell at a glance whether they're bothered by function issues in terms of reading and hobbies and that sort of thing, or whether they are bothered by psychosocial issues. And it tells me, it actually saves me a lot of time in terms of history taking by using these types of questionnaires. And I have no financial interest. We deliberately made them publicly available. I'm not trying to flog you anything here. We made them free and publicly available. And then we went through the validation and made sure that indeed that cataract patients and glaucoma patients don't have these problems unless they have strabismus. And these are some of the validation studies. And then the question is, does it actually improve after you successfully align? And this is the guy who's 33, and after his surgery, he's then much better aligned. And indeed, we showed that the psychosocial things scores improved and the function scores improved, even in patients who didn't have double vision. So we saw psychosocial improvement and functional improvement both in diplopic patients and in non-diplopic patients. And then one question would be, well, wait a second now, they've paid good money, some of them, or they've paid their deductible at least, to have this surgery. Maybe they just score better because they want to feel better about spending that money on having their surgery. And so we did a small study where we looked at patients who we would objectively classify as successes, very small microstrabismus after the surgery, partial successes, an improvement in the angle but not great. And we had a couple of failures. Thankfully, we didn't have very many, but everybody does have some surgical failures, that angle was only a little bit better or essentially unchanged. And what we found was actually, as we had hoped, that the success rate, the successful patients had good improvement of scores, whereas the failures did not. So this didn't seem to be a psychosocial effect. We've gone on with further analyses of these questionnaires, and now the up-to-date method is to actually divide it into 4 domains. The psychosocial domain, it has a self-perception 4 questions and an interaction 4 questions. The function domain has a reading 4 questions and a general function. And so if you care to, you can analyze it separately. And I think one thing that we learned by doing that is that we weren't expecting it, but the patients who had no diplopia going in, no diplopia coming out, who really had an improvement in their psychosocial, they also had improvement in their reading and in their general function. And one question is, how on earth does that happen? And the answer is, well, some things happen. Maybe you get an expansion of the binocular field, particularly in patients who are esotropic. Bringing their eyes to straight gives them a binocular field. The caveat is someone who's got a very large XT. There's a famous case in von Norden's textbook with a guy who was a mail carrier deliverer, and he was straightened by von Norden, one of the great, and the patient was super unhappy, and von Norden said, well, what's going on? He said, well, I was used to being able to drive with one eye and be able to stuff the mailboxes with my other eye. And now that you've straightened me, I can't do that as well. And so take a careful history in terms of what you do at work. And I did have one patient who complained to me about something related, is that they were a college basketball star. And they said they could see the whole court with their very large angle exotropia. And they used that more than they needed the depth perception to, pop the basket. And when I straightened them, it's, yeah, my depth perception is better, but I can't see the whole court anymore. So take a careful history when you're planning these surgeries. So even in non-diplopic adults, not only do we see a psychosocial benefit, but in most of them we see some functional benefit. Just a couple of additional thoughts on diplopia as we end this part of the lecture. It kind of goes without saying that patients don't want to wear a black patch. Very few people are kind of into that black patch look, and that's one of the reasons why we get patients who want strabismus surgery. But they also, and this happens now in my practice, I'm practicing in Tucson, and part of my population is the snowbirds who come down and the retirees who come down, and they are persuaded by the cataract surgeons to invest a significant sum of money into premium IOLs. And what these patients don't want to do is invest that money into premium IOLs and then be told, well, you see great, you've got 20/20 uncorrected vision, but you know that small strabismus that you have, that misalignment, you're still going to have to wear prism glasses. And so the good news is that we have developed over the last few years techniques that allow us to pretty much address any angle of strabismus. When I was training 20, 30 years ago, I had even my strabismus mentors would see a patient with a 2 prism diopter deviation, and they'd say, that's too small for surgery, you're going to have to wear prism. But the good news is, there's pretty much no deviation that's too small for strabismus surgery. But the caveat is, prism has to work. In other words, you have to be able to hold prism up and show that the patient gets the benefit. Because all we're doing in strabismus surgery is just duplicating the effect mechanically, what the optical effect of the prism is. And so there are a couple of conditions, one of which is dragged fovea diplopia, which we're going to talk about in the second talk, where the patient is not comfortable with ground prism. And a few of those unfortunate patients go through some of these more subtle techniques, and they don't have benefit because it wasn't shown before they went to surgery that they could benefit from prism. So the patient has to be able to show us that they can benefit, and it can be a trial in the office. It can be a prolonged trial. In fact, what I do is I just have them hold that 2 base down, and I just have them continue to read the chart while I'm finishing up my note. And I say, tell me if it splits. And the patient with dragged fovea diplopia, and again, we'll get into that in a few minutes here, will, after a few seconds, go, oh, it's gone into double again. And you're chasing that double, and you've got to give them, unfortunately, you have to be a little patient with them and give them a minute or two just to see whether it's gonna split on them. And so one of my more common procedures nowadays is to do what I call a pole recession or a partial tenotomy, which is that one of the disadvantages of the old way of doing it is when you took the whole muscle off and recessed the whole muscle, you sometimes would overcorrect a tiny deviation. And so for those of you who do strabismus surgery, this is a great technique where you just imbricate 1/3 of the muscle, and then you just hang that pole back, leaving about 2 millimeters of muscle attached. And you get about a 50% effect from your usual dose tables. And because I like to do almost everything on adjustable sutures, this lends itself to adjustable suture, and I like to adjust them in the recovery room right away, and so it's something that I can do. And so this is my go-to procedure for those 2 and 3 and 4 prism diopter deviations. And there's kind of a spectrum of what we do here. There's another technique which is called a snip procedure, and this, if you have a good procedure room in your clinic, you can actually do these in your clinic because you just numb up the conj with a little bit of lidocaine, open it up. You need a cautery just to touch those vessels, and then you just snip the pole of the muscle, and then you just sit them up, and then just measure them again, and then you just keep snipping. This is a one-way surgery, so if you snip too much, you can't take it away. You go back, you have to take the patient to the OR and put a suture in it. But if you snip millimeter by millimeter, you can get, and I reserve this for the 1s and 2 prism diopter deviations. Joe Diemer, my colleague at UCLA, he'll do this procedure for more than that, for up to 8 or so prism diopters. I prefer the control of the pole recession that on an adjustable is the way I do it. But this is, again, a technique. But for those of you who don't do it, the take-home message is you don't have to prescribe 1 and 2 prism diopters of deviation. You can refer it to a strabismus surgeon who's doing this. Let's see if we can move this forward. Here we go. So this is the worst example of this, is that here's a poor patient who had bilateral cataracts. He had multifocals put in. He paid good money for that. They didn't work so well. He was complaining of blur, and so he wasn't happy, complaining of he got intermittent diplopia. Unfortunately, the cataract surgeon didn't do the most careful exam or refer it to a strabismus colleague, because the next thing the cataract surgeon did was a bilateral IOL exchange, and he couldn't nail it with multifocals. This time I'm going to put in light adjustable lenses, and we're going to nail that refractive error, right? So he nailed the refractive error, but the patient's then saying, but I've still got kind of blurry, intermittent double vision. And so he'd had 4 premium IOLs, and he was still unhappy. And so then he ends up in my office, and yeah, he's got a 1 prism diopter intermittent hypertropia. He's got asymmetric amplitudes, and I'm a big believer in using the prism bar to actually demonstrate that the patient is either balanced or imbalanced. And this is how we find, as strabismus specialists, our one prism diopter deviations, because they're hard to see, even on a prolonged, but if you use your prism bar, you can show that they're on the edge, they split with one more, and they recover at 0. But they've got amplitudes on the other side, for example, 3/2, that he's pretty comfortable with a 1 base down. And then you can reproduce that with one of these lesser surgeries. For example, the snip procedure, which I did on this guy, and he was happy with that. So my take-home message from this lecture is that whether the deviation is 1 prism diopters or 90 prism diopters, we can still offer them solutions. Some patients are happy with prism, and that's great, but we still have surgical solutions for that. So in summary, why do we treat patients with strabismus or adults with strabismus? Because they can start out with symptoms of diplopia or strain. They clearly have reduced health-related quality of life, and we can actually measure that now with the AS20. We can put a number on it. It affects them psychosocially, it affects them functionally. And those effects are not just in diplopic patients, but also in the non-diplopic patients. And now in the strabismus world and in the diplopia world, have questionnaires which you can download from this website. Feel free to use them in your practice. And then so hopefully we can then move from a time where we just think of it as a burden, is actually getting the patients to fill these out, that we can actually move into a world where we use patient-reported outcome measures, perhaps even in routine practice, and that's certainly what I do, to evaluate what the patient is experiencing. And that we can use them then in research to then maybe distinguish between different approaches to these patient problems. So I'd like to thank my team, and thank you for your attention. Thanks very much. And maybe I'll pause there because I'll move into a completely different mode. So I'll take any questions or comments or concerns from, if anyone has any. Yeah, please.
When you snip at the pulse, do you get any torsion?
Yeah, no, it's a very good question. One of my residents just presented at the APOS meeting a month or so ago, our first retrospective look at that. The short answer is very little. The caveat is that we found the most change in the superior rectus temporal pole. And the way, and I encourage trainees and colleagues and myself to imagine this is my right eye, and here's my superior rectus. The superior rectus is an encyclotorder, and so when you actually cut the fibers that are most effective at encycloing the eye, you're going to reduce the encyclo, so you're going to get a little bit of excyclo. So the important take-home message there is know what the torsional status of your patient is before you go into surgery. And we do that in a couple of ways. One is that most of us use double Maddox rods to measure that, and I'm a big believer in measuring it 3 times. I know it's a bit of a hassle, but it's actually quite quick. There is enough variability that taking the average of 3 measures is really, really useful. But what I teach the residents in my program is most patients confuse up to 5 degrees of excyclo and 5 degrees of incyclo. Now, there's a very rare patient where that's a problem, and then you really need access to a synoptophore to sort that patient, that rare patient out, and we'll get into it in a second in my next talk. But if you have a patient who, let's say, has 1 or 2 of excyclo, which is very physiologic, and a lot of patients are walking around with 1 or 2 of excyclo, then these pole or snip procedures do not induce any more than 2 or 3 of excyclo. And that's even when you do the temporal pole. If you do the nasal pole, you get even less than that. You're getting around 1 degree, which the patient isn't going to be symptomatic on. So that's a great question, and it leads into, if you're going to be doing a whole recession of the superior rectus or the inferior rectus, the same principle applies, which is know your preoperative torsional status to figure out whether you're going to do harm and tip the patient over to the edge. So in the same way that I use a prism bar to see whether the patient is vertically on the edge, and that's what I use to find those really small deviations, I will actually put the patient on the synoptophore, and you'll see pictures in a second, to see whether a patient is torsionally on the edge, particularly if they're measuring more than 5. It may be that the patient isn't complaining of torsional diplopia. That's the tip-off that they're really in trouble torsionally. But if you are able to work with an orthoptist, or you have access to a synoptophore, and you must have fusible targets, and I use the house targets, which you'll see in a second. You can see it's the only way you can actually change, if you like, the torsional demand or the torsional stress on the visual system to see whether or not the patient will run into trouble. I guess if you back off that, and if the patient says, well, intermittently that second image is rotated, then the alarm bell should be going off in your head and say, well, wait a second now, this is more than just a vertical deviation. And then if the patient's complaining of a rotated image, then you want to ask yourself, well, what am I measuring on double Maddox? And then will the surgery that I'm planning to do cause that to be a problem in this particular patient? So, great question. Yeah.
Orbital trauma patients, like blowout
Yeah.
fractures, things like that, tend to have some form or some complaint, could be the reading or
Mhm.
diplopia of some kind. How late or how long you are wait before you would attempt a surgery like that or send it for a surgery like that?
Yeah, right. No, the orbital trauma patients are some of the more challenging because they can have this combination of weakness of a muscle and tightness of a muscle. And so that can give them, if they don't have a problem in the straight ahead, maybe they have it in slight up gaze, and then when they go to read, they then have a weakness, and so they do. And sometimes we're just shooting for a better compromise so they can function. But in a specific answer to your question, I would say at least 6 months before you intervene. But so maybe referring at 3 or 4-ish months to see if we can get some initial measurements, then we can see whether it's stable. So yeah, at least 6 months, even if you're being fairly aggressive. But clearly, if the orbital surgeon has decided that they need some reconstruction, then it's another maybe 6 months after that. You want to be done with repairing the orbit. Often we get it to, well, does the orbit need to be repaired? And there's kind of going to be a debate with the oculoplastic surgeon on that, or maybe it'll be pretty clear. And then if they're going to go ahead and do it, and then and then go from there, and then customize it, because and that's where actually the questionnaire. If you're not going to use the questionnaire, then ask the questions and then document it down, which is where are you having problems, basically, and figure out how does the double vision, because the post blowout patient is one where it really has to be customized, because for some occasionally you get a patient who is they actually, I made the comment on, bicycles maybe not matter, but occasionally you have a patient who really is a recreation or even a professional, and they really need biking, and they put their head down and their double vision is an up gaze, and then you have to think about, what can I do to help their up gaze? And then we get into the whole business of often having to persuade the patient that we have to operate on the other eye, and in post-blowout patients, that takes a lot of persuading, because they say, well, what do you mean, doctor? My problem's in my right eye. That's the one that got smashed up. Why are you going to be even thinking about operating in the other eye? But in strabismus, we often have to balance ductions, and sometimes we have to do posterior fixation in the other eye to balance that, particularly in down gaze, which is the problem that you mentioned. If the down gaze problem is really severe, then we do go to the same eye and use transposition procedures to pull the eye down. The common theme is we can never make these patients perfect, but the idea is give them some straight ahead and some reading. So I'm always drawing this picture to them. We're trying to give you this area of single that encompasses straight ahead and down gaze. All right. Yeah.
So with respect to the microstrabismus,
Yeah.
how do you reconcile that, their symptoms, with what we know about monofixations?
Yeah, so it comes down to symptoms, basically. So in classic monofixation syndrome, it's a childhood onset and they don't have diplopia. If they have childhood onset and they do have diplopia, one of the most common causes of that is they've slipped out of that suppression scotoma. And then you figure out with PRISM what will it take to get them back into that suppression scotoma. You then pivot to these other patients who tend to be adult onset strabismus, whether they're blowout fractures, whether they're cranial nerve palsies, whether they're thyroid patients, and these elderly patients are often sagging eye patients, where they may have an ET in the distance, but they also have a very small vertical, and the typical patient is, and sagging eye is terrible because the patients get kind of offended when you say you got sagging eye syndrome. And in fact, it's a misnomer because it's the muscles that sag, not the eye that sags. Be that as it may, your typical patient has double vision. They're 70-year-old, and they come in and they say, I got double vision when I'm driving. And they've got a little limitation of abduction. They've got a 10 ET in the distance. Okay, so you're going to have to do a bilateral medial rectus recession for that, but sometimes they have a 2 of a hyper. And what you'll discover with prisms in the office is that 2 of the hyper is important to correct. So you'll hold up the 10 base out, and they won't have, some of them will have single, and it's great. Okay, we're kind of home free, we'll go ahead. Although actually, I like to do amplitudes vertically to make sure that they're not on the edge vertically. But often you'll hold up the 10 base out, they'll say, but I still see double. And then you'll ask them, is the double side by side or is double up and down? Double's up and down. And then you'll take your vertical prism bar and you'll hold it up, and then they'll fuse and go, okay, we're going to have to correct both your horizontal and your vertical. So this is a very common procedure that I have to do on many 70, 80, and I do them under topical on the 80 and 90-year-olds because I'm a little afraid of putting a 96-year-old under a general anesthetic, and you can do these under topical. But I'll typically do a bilateral medial rectus recession, and then I'll do a pole recession to get that vertical. I really shy away from doing stage procedure. If I know going in that the vertical is a barrier to fusion, then I'm going to do a small procedure like this. And so to come back to your question, you distinguish it from monofixation because the histories are completely different. This wasn't childhood onset strabismus. This was, an 80-year-old or a 70-year-old who suddenly started getting double vision driving one day, and they look for all the world as they have an ET, but they also have that small vertical. And the way that Joe Dima talks about it is that it's not the symmetric dropping of the laterals, which is the typical cause, but it's slightly asymmetric, so one lateral is further down. Why don't we lift one lateral up? Because we can't do it in a very titratable way, and so moving one vertical rectus muscle, and sometimes if there's a little ex-cyclo, I'd prefer to do the inferior rectus to try to take care of which was related to one of your original questions. So I tried not to make the torsion worse. But follow-up question.
Why wouldn't you do Yokoyama?
So the Yokoyama procedure is kind of reserved for the true heavy eye, which is where the eyeball has kind of pushed its way between the superior rectus and the lateral rectus. And so we're still trying to collect data as a field to figure out what is the critical angle that you can see on a CT or an MRI where you absolutely have to do a Yokoyama. My rule is that if there's any limitation of elevation, which is asymmetric, then it's an easier decision to say, well, I'm going to have to join those. And they also have moderate to high myopia, like -7, -8, -10. In the patients that I'm talking about who are the typical 60, 70, 80-year-old who have a 2-prism diopter hypertropia, I think the danger of overcorrecting that with a Yokoyama is very, very high, and it's not very titratable. I mean, you could theoretically put your joining suture. The Yokoyama procedure, for those of you who aren't completely familiar, it's a joining where you join the displaced superior rectus to the displaced lateral rectus, and you tie the bellies together 12 millimeters back from the insertion. It's not a very titratable thing, and I would reserve it for when it's really needed, which is in the high myope Yokoyama who's got limited elevation as well as limited abduction. Having said that, it's a good question because our current understanding is that these exist on a spectrum. And I was on a call with my pediatric colleagues. We're about to start a prospective data collection of myopes who have esotropia, and to try to figure out an answer to your question, which is when do you have to start thinking about a Yokoyama versus when can you get away with a bilateral medial rectus recession and a pole recession on the superior rectus? The short answer is the titratability and what you need to fix the problem. If you only have a 10 ET and a 2 hyper or even a 6 hyper, you can fix that with a bilateral medial rectus recession and a pole recession, or even if it's a 6 prism diopter hyper, even just a small recession of the full superior rectus. All right, I better get on to the next topic. I'll wait for my slides to come up on talk 2 here. So diplopia in retina conditions. Will it also show here so that, all right. So no financial interest. So I'm going to go through basically 3 cases to illustrate this principle, which is that I think of double vision associated with retina conditions as straightforward strabismus, which I'll call macro misregistration, and micro misregistration, which is the dragged fovea diplopia or central peripheral rivalry. So the macro strabismus that's most common with a patient who's got a retinal problem is either post-scleral buckle, or there's something that we've started to recognize more, which is the patient had a retinal detachment. They didn't have a scleral buckle. They had a vitrectomy, but they're complaining of double vision. The micro misregistration, which is the dragged fovea diplopia, or what I call central peripheral rivalry, is where the foveas are out of alignment, but the peripheries are in alignment. And you can end up with patients who have combinations of these 2 problems. So let's start with case number 1. Case number 1 is a patient who did have a scleral buckle. So I'm going to go through some tips as to how to deal with that. And essentially, the thought process is, now they're out of sync, which is kind of an interesting thing, right? So when the slides on the, okay, here we go. Now we're in sync, so that would be a bit of a challenge. So you've reduced my challenge here. So actually, let me go back, because there's a, this is the, so you'll see from this diagram that macro misregistration is really just straightforward strabismus, which in the context of scleral buckle or not, you can have horizontal, vertical, and torsional components, just straightforward strabismus. The thing that kills us with micro misregistration is that the peripheries seem to be aligned, but the 2 foveas are not aligned, and the patient is kind of going in and out between fusing the foveas and fusing the peripheries. And that's most common with ERMs. And so it's actually pretty common for those of you who do cataract and anterior segment surgery, is that this isn't recognized until you've actually done great cataract surgery. And now they've even got great vision, they're 20/25 plus, and they say, but doc, I've got double vision. And it's like, really? And you can hardly see that tiny, tiny vertical thing. And I'll give you some tips in the 3rd case on that. So let's go back to case 1, which is the gentleman who's had scleral buckle. And this patient is complaining of all 3 types of diplopia. It's got horizontal, vertical, and torsional. And one take-home message from this part of the talk is think about which muscles are restricted, which muscles are being involved by either the scleral buckle or the healing around the scleral buckle. And if you have X cyclo, which you're going to measure with double Maddox, and the eye doesn't go down, then you just need to be aware of this condition, which is superior oblique entrapment. And what I like to teach the residents who are learning strabismus surgery is that when you're putting a hook on the superior rectus, be mindful of where the superior oblique is, because this is how the retinal surgeons get into trouble. They put their hook in too deep. They don't know they've caught the superior oblique, and they drag it forward. They then put their traction suture through the same hole, and they don't know that they've got their black silk suture on the superior oblique. They just don't recognize that. And then they put their buckle in through the same hole, and what they've done is they've dragged then permanently the superior oblique up to the superior rectus. And these patients typically have X-cyclo because their superior oblique's in the wrong position and it's weak, and they have a high PER because the eye can't get down because the superior oblique is acting as a leash. It's a tether. It's stopping the eye going down. That's in contrast to the other common thing, which is where the retinal surgeon hasn't caught the superior oblique, but they've gotten enough scarring with the buccal that they've got a inferior rectus restriction or tightness. And so these are like common things that you just need to know in your head to be looking for, and it becomes apparent when you do forceductions. And then if you suspect this situation, which is the eye doesn't go down and the patient's got X-cyclo, then you know where to look. And this is a bloody picture, but basically with a little bit of help with some drawing, you can see how the superior oblique tendon is now inserting at the nasal pole of the superior rectus. This is surgeon's view. Top of the eye is at the bottom of the picture. And the superior oblique tendon is at the nasal pole. And if you don't know to look there, then you won't look there, and you'll never sort out this case. So this is kind of a look and see. Before you get to that, this is one of the common things that you see when you're doing strabismus surgery. It's a complete nightmare after sclerobuccal surgery, is that you see what I call the frozen sea of scar. It's just like a white scar. And you say, well, where on earth are the muscles? And the one thing that you need to know how to do is to get the hook on much further back, and sometimes you even have to do sharp dissection to get a hook on the muscle because it's so scarred. But then a tip for those of you who do strabismus surgery is to do sharp dissection forward, and the reason is because the muscle is there, but it's gotten completely embedded in that scar tissue. So you have to sharp dissect forward. And you often have to sharp dissect between the muscle and what I call the cocoon, which is what the scleral buccal is in a scarred cocoon, and you can separate it from. And as Steve Archer, my mentor 30 years ago, used to say, you go from something that looks like a white or pink-white sea of scar to something that looks more like a muscle. And you can actually save a lot of muscle tissue this way by knowing that if you dissect forward, you can actually free up the muscle and get it there. And you can leave the buccal. They're typically solid silicon buccals. Just leave them alone and leave them in their cocoons, embedding the sclera. And that way you don't have to worry about taking the buccal out and then having the patient redetach, because every time you take a buccal out, there's going to be a risk of redetachment. And actually, the sad story is that some retinal surgeons, they see these patients with double vision, and then they take them to the operating room and say, well, just take the buccal out. And then 99% of the time, that removal of the buccal does not help their double vision because it's all locked in with scar. So a better thing is forget the trip to the OR with the retinal surgeon and just say the buccal's going to stay there. I'm going to work around the buccal and leave it in place. You're going to have to do a fair amount of sharp dissection to free the muscle from the buccal. And this is what you do. You hang the muscles over the silicon bands, and you leave the silicon bands in place. And you can do that. I didn't know differently, but I hang them back with Vicryls, and I even leave that muscle sitting on that silicone. And the answer is, why doesn't it, when the Vicryl dissolves, just like fall off? It's because the scar tissue forms faster than the Vicryl dissolves. And so you can get away with using Vicryl and not worrying about losing a muscle because it's going to sit down. It's going to sit down on the fibrin and then sit down on the fibrosis. So this gentleman who had these three vertical, horizontal, and torsional, we recessed the right superior rectus for the hyper, we repositioned the superior oblique for the X-cyclo, we recessed the right lateral for the XT, and he didn't do perfectly, and you tell the patients, my mantra with these patients is that one surgery has approximately 50% chance of making you somewhat happy. The chance of me needing to do a touch-up is higher than almost any other type of strabismus. So I warn them about that. And it's better to under-promise and over-deliver. I'm not sure that I actually do take 50% of my patients back. But I tend to under-promise and try to over-deliver. And then sometimes these patients need a small vertical prism to take care. They have the option of going back, but sometimes they've been through a lot. They don't want to go back. So that's a patient who had a scleral buckle, and just be aware of that superior oblique, because if you don't know about it, you don't know to look at the superior rectus to find the superior oblique. Here's a patient, and I had another resident who presented like 6 of these at the latest APOS meeting, because I get like 1 a year. And I'm not sure why I'm seeing like 1 a year. Maybe I'm getting smarter identifying it. But these patients, they have Makoff retinal detachments. They have beautiful surgery by the retinal surgeon, but they end up in my office with twisting double vision. Twisting and vertical double vision. And I go, well, what type of buckle did they put in? Well, they didn't have a buckle. So I get the record, and they didn't put it in a buckle. And there's no scarring. And so, well, wait a second now. What's going on here? This patient had a small hyper. And you think, well, they've got a small common hyper. Just put him in prism. They were put in prism by a good optometrist, and the patient's still complaining of double. Why? Because they have 10 degrees of X-cyclo. So they exceeded my usual threshold of 5 degrees. Now I have another one of these patients who only had 3 degrees, and actually I figured that out by putting them on the synoptophore. But a good starting point, if they have more than 5, they may not be able to fuse it. And here they are. This is the only reason why I look at the fundus, is to sort of confirm that they have X-cyclo. Now, the problem with this is you can't use it for surgical planning, because a normal patient who's never had a retinal detachment, never had anything, they will have X-cyclo that can vary from, or can be from 0 in some patients to 13 degrees in another. So you can't look at it, and some people have used, OCTs, and they've measured the X-cyclo to the nearest, 0.1, and it's like irrelevant, because your normal anatomic variation is all through that range. The deal is, are you symptomatic? Are you complaining? Are you complaining of, well, particularly if you're complaining of torsional diplopia, but if you're complaining of any diplopia, then you want to figure out, is torsion a barrier to fusion? So you start out measuring the double Maddox, and then you stick them on the synoptophore. And it's not the old line in the cage that they used to do. It has to be something they can fuse. And so these are the only targets. They sit permanently in my synoptophore. They're the house targets, because they're square. They have fusion clues, the houses, and the idea is, what does it take to fuse? And you correct the vertical, you correct the horizontal, and if they say it's still not right, then you start changing the torsion, and you figure out, do they need torsion to fuse? So this patient needed both the vertical and the torsion to fuse. So that's actually why the prism didn't work, and why the patient needed the torsion to be corrected. And we have great ways of correcting torsion. For me, my go-to is a Harada Ido. I say to some of my residents, the Japanese have all the great strabismus procedures. My colleague in the back mentioned the Yokoyama procedure. I know it's like one of those. I know Dr. Yokoyama. He's still alive, still in Japan. I think Harada and Ido have passed away. But Harada and Ido, because in the 60s, described actually pulling the anterior fibers down. Now, I can put the anterior fibers on an adjustable suture, and I carry my double Maddox in my pocket. I changed my jacket today, so they're not in my pocket right now. But they're in my work pocket, and I measure the torsion in the recovery room, because I like to leave them with a slight overcorrection. I'm shooting for 7 degrees of in-cyclo in the recovery room, because they're going to unwind. So actually, in this patient, you can see in the bottom of this slide, is that they only had 2 degrees of in-cyclo in the recovery room, so I advanced the superior oblique anterior fibers in the recovery room to give them 7 degrees, and they ended up doing great, and didn't need prism glasses. Yes, I induced a tiny browns. Yes, they had a little bit of double in far and up gaze. You never get perfection, but this patient couldn't function driving and couldn't read comfortably, and so I'm shooting for straight ahead and for reading. Okay, last case. So this is the typical patient with dragged fovea diplopia. Intermittent overlapping images when they're either reading, or when they're on a computer, or when they're looking at the subtitles on the TV, or the ticker tape on the TV. He's a known epiretinal membrane, but he's got great vision. So the retina people don't want to touch him, or many retina people don't want to touch him because he's got 20/25 vision in his epiretinal membrane. But, and this is how you'll tell, is that in the office, you'll put up a single optotype and you'll ask them, just look at it, look at it, look at it. And then they say, oh, now it's double. So often they can intermittently get it fused, but as they stare at it, then it will become double. Often looking away or just looking at a general room, everything will be single, and then they'll come back and then it'll split. If you do a cover test, you'll often find a very small hyper. And then when you take out your prism bar, you'll be able to correct it, but then if you have them hold the prism bar, I often give them a free prism just to hold that one or two, and I say, look at it, look at it, look at it, and I'm typing my note. Oh, now it's double. This is so typical. It's not always this way, but it's very, very typical. And as we talked about, we originally conceptualized this 20 years ago as being either to align the foveas or to align the peripheries. And in the bad cases, you could actually see on an OCT that it was actually very, very dragged out of position. But as we've studied this and actually listened to the patients, we've found that you don't actually have to see XY dragging of the fovea. Sometimes the fovea is just scrunched. Not a great scientific word, but it's because the membrane is dragging the fovea inwards, and the photoreceptors are now packed at a different density. And that is associated with difference in image sizes. So if you take a second and ask the patient, look at the big 2200E, compare it with your normal eye, now tell me about it with your other eye, they'll tell you that it's actually a different size. And because they're packed more tightly, the most common is that it's larger. Not always, but it tends to be larger. Now, Dave Guyton, who's been describing this condition for a couple of decades, came up with this test, which is the lights on, lights off test. And so he will, on his monitors, he can present a white letter, and then he allows it to go double, and then what he does is he turns all the lights off. And it has to be all the lights off in the room. And then because there's no peripheral clues, the patient will be able to fuse the center. And then that's diagnostic of this. I've had a problem with this because I can't get all the lights off in some of my rooms, computer monitor. And so as I sort of brainstormed about this, we came up about 10 years ago with what I call the optotype frame test. Most monitors have a black frame at the edge, no matter what you're using. And you can put up a 2040 or a 2050 letter, and you can say, look at it, look at it, look at it. And then when it becomes double, they say it's double. And then you say, while you're looking at the double, in your peripheral vision, is the monitor double or not? And the answer is, in these patients, often no. They've got a double letter, but they've got a single frame. If a patient has a small true hyper, like the patients we've just been discussing in the previous talk, they have a true 2 of a hyper, they will typically say the whole thing is double. The letter is double, the frame is double, because the whole thing is misregistered. It's not just a difference between the fovea and the periphery. We mentioned anisoconia. You can do that just by asking the size of the letter. The Japanese developed the Awaya. They have all the good tests as well as all the good surgery. The Awaya test, you can actually put a number on the patient's difference in size. And they actually have, this is the AMSLA to assess metamorphopsia, but they actually have something called M-charts where you can actually put a number on the distortion, the amount of distortion. Okay, so you've identified this poor patient who's got dragged fovea diplopia. They have an epiretinal membrane. How are you going to treat it? Well, we went back over our charts a few years ago and looked at the trials of treatment. Now, Dave Guyton at Hopkins has advocated using Scotch satin tape. And you can fashion the tape just as a small square over the fovea. And some patients are happy with that. You can actually also use a Bangita filter. It's the same principle. It's to knock down the contrast in that eye. When we used our rigorous diplopia questionnaire and only categorized success as rarely or never, we surprisingly only had about a 14% success and Dr. Guyton doesn't like it when I say this because he thinks that in his hands, his pieces of tape actually works better than this. And so I'll just mention it is that I'll offer it to the patient, I'll put it on. It's an easy thing to send them home with. They can try it, they can cut it. They particularly don't like it if it happens to be their dominant eye. If it happens to be their non-dominant eye, they do okay with it. But if it's their dominant eye, they just don't like it. Now, we've been down this road, and I'll mention it because I think it's really worth saying, is that we found no success with ground-in prism. And Dr. Guyton, in many of his talks, talks about the number of patients that have seen him that with ground-in prism, they just build fusional amplitudes, and they end up building their 2 hyper to a 4 hyper to an 8 hyper, and they end up then having a strabismus that you really have to fix. And so really the ground-in prism doesn't work because they're constantly choosing between, am I fusing the vertical, am I fusing the periphery, or am I fusing the fovea? The other flip side of this is related to my first talk, which is that only think about these snip procedures or these pole recessions or these partial tenotomies if you can demonstrate fusion. So a pure dragged fovea diplopia patient is no candidate for a snip procedure or a pole recession because you can't demonstrate that they're happy with prism, so you can't duplicate that, and that's a really important thing. It's really interesting that Fresnel prism works much, much better than ground-in prism. And these are some of the few patients who wear Fresnel prisms for months and months, and some of them wear them for years. Well, why on earth does that work? And we postulate that it's because the Fresnel prism also reduces the contrast. So you've got this combination of using something like tape, something like a Bangada, with a little prism correction, and they seem to like this. So this is just something you can certainly consider. Because of that anisoconia, I had access to a really great optometry colleague who liked to work with anisoconic lenses. And so I did find one patient who described pretty much symmetric enlargement of the image. And so we actually made that patient much happier with an anisoconic lens. Only happened in one of these patients, and so the failure rate is really high with this, but I'll just put it out there, is that people with regular anisoconia might find relief from using that. But this is the most surprising thing and probably the most controversial thing about this topic, which is that I had a very aggressive vitreoretinal surgeon as a partner in my practice at Mayo, Ray Ayezi. And he was pretty confident that he could do membrane peeling on these 20/25, 20/30 eyes, even 20/20 eyes, and not cause the complications. And never say never, because you have to tell the patient there's a chance that you will develop a cataract if you don't have a cataract. So the best patients for this are patients who are already pseudophakic, and many of them are. Many of them are already pseudophakic. But membrane peeling has a role. And Dr. Guyton, again, has published that it doesn't, but it's interestingly is that the data talks. And about almost a half of the patient, I say between 30, depending on our initial series, it was 30%. As we gathered more data, it was in the 40s. So somewhere in the 40% of patients actually have success. Diplopia rarely and never, straight ahead and reading, either with vitrectomy membrane peel alone or with the help of a tiny amount of ground-in prism. And why does that happen? And here's a picture. Top picture is pre-op. Patient had 20/25 vision with that membrane, but what you see in the bottom picture, not only is the membrane gone, but the most important thing is the foveal architecture is much, much improved. And we postulate that the photoreceptors then regain a much more normal architecture. Now, you have to warn the patient that it's glass half empty, glass half full, because at least half of them, even after the best vitrectomy and best membrane peeling, the photoreceptors will not go back into a normal arrangement, and they will still have exactly the same symptoms that they came to you with, and they will be extremely disappointed. But with the right counseling for the patient who is at the end of their rope, working with a good vitreoretinal colleague is something that you should consider. Now, that isn't the end of the story with this particular patient, so I'm going to throw you another curveball, is that this patient actually described a twisting image before I could get him to the retina colleague. And when I put him back on the synoptophore, he actually saw a difference between whether the torsion was corrected or not. So this patient taught me that I just need to keep listening to what the patient is telling me. And if the patient is not just he has classic signs of dragged fovea diplopia, but if the patient is telling me they have a twisted image, I better figure out how much torsion they have, and I better put them on the synoptophore. So this patient underwent a Harada-Ito variant where I advanced the anterior fibers, and this patient did really well, and reported to me in their post-op period that they were 99% better without touching the retina. And we actually then did all the testing, and he still had all the metamorphopsia and the positive optotype frame test, but his symptoms were better. And so for each individual patient, and this is a common theme that goes through both of these talks, is we have to figure out for an individual patient what is their barrier to fusion and how can we improve them. So my final take-home messages are: know about superior oblique entrapment, because it pretty much only happens when the retinal surgeon drags the superior oblique forward. Know that we have to figure out what the restrictions are and what the barriers to fusion are, and you don't have to remove buccals in 99%. And in dragged fovea diplopia, offer them these other conservative measures, but know that working with a vitreoretinal surgeon may help some of our patients. If you're interested in strabismus, I want to give you a welcome to our meeting in Buenos Aires at the end of the year. There are also great trips to Patagonia and some great hiking to be done around there. So I commend that meeting to you. And thank you very much for your attention, and take any questions.
For your original patient who has the sagging eye syndrome,
Yeah.
and I think you mentioned you sometimes will do check their horizontal amplitudes of divergence and convergence.
Right.
And you mentioned you check for the vertical too, and try to do all three at once. Let's say that the divergence amplitudes are weak. Do you still do medial rectus recessions?
No, I mean, that's a great question. So it's a very unusual patient that doesn't have symptoms on at least lateral gazes. So I do have a group of patients where they're basically like a 2 of an esophoria in the straight ahead position. And they do have like weak divergence amplitudes, because no one has really strong divergence amplitudes. But if I'm talking to them, they say, yeah, but when I'm driving and I look way over to the side, then I get double vision. And some of those only have a 4-prism diopter intermittent ET in lateral gazes. And it's often symmetric. It can be asymmetric. But I know that if I don't do something for the horizontal system, then they're still going to be symptomatic. So I've actually, over the years, become a little bit more aggressive with those patients, and I'll do 3mm bilateral medial rectus recessions for 4-prism diopter esotropias in lateral gazes, and those patients have been happy with that. Now, if they have an added vertical, I'll also do a pole recession or a snip at the same time to take care of that. So I think, again, the common theme is listen to the patient and then do the exam. If they had nothing in lateral gazes and they're asymptomatic and I can't pull it out of them, then in that rare patient, I'm not going to go hunting I misspoke. I will hunt for it in my exam, but I'm not going to be adding to my surgical plan just because they're 2E on lateral gazes and they're breaking at 2 or 4, because a lot of people are breaking at 2 and 4. I'd more listen to the history, because the history is going to tell me, are they symptomatic in lateral gazes? I mean, we all see these patients all the time, which they're driving, they're okay, but when it goes to, looking left or looking right, that's when they get most of their double vision. When they have a very small angle in primary and a bigger but small angle in lateral gazes. Yeah, so I customize it, but yeah, and then sometimes what I'll do is, usually you can tell from how quickly they break. So the patient's got 2 esophoria in primary. If they're breaking with 2, then, and they're saying that they're intermittently getting double vision just driving straight ahead, well, kind of there's the answer, right? So those patients are asking for something which is it's either prism or it's surgery. Those are their two options. So I then circle back around to my first talk, which is, listen to the patient, listen to the patient, listen to the patient. What I like to say to their residents is that, in ophthalmology residency, we're all too quick to, first thing we do is grab the slit lamp and wheel it in, or maybe even for strabismus people, grab our prisms and start measuring. If we pause and say, how can I help you today? What is bothering you? What are your, primary concerns? I think that then helps us get really focused on how we can help the patient. But yeah, and so one of the themes is I think we can now, and I think this has evolved probably over the last decade. If I think about what we were offering patients a decade ago, I think that these techniques now allow us to offer. Sure, prism's great, and some patients are happy with it, but some patients really, really want to be out of prism for most of their activities, and they're okay with pulling out their reading glasses out of their pocket, but they just want to function, hike and bike and drive without glasses. And now that it kind of parallels the anterior segment world where everybody's got ways of maximizing the chance of that distance 20/20 outcome. And so, whether it's through toric lenses, whether it's through, light adjustable lenses or whatever, more patients are getting 20/20. Now, I will say that please avoid monovision in patients who have any signs of strabismus or any history of childhood strabismus, because monovision is a setup for another challenge for the fusion system. And so if the patient has any history of childhood strabismus or patching or exercise as a child, or they have any history of diplopia, either remotely or now, as intermittent as it might be, don't give them one eye in focus for distance and one eye in focus for near. As much as the patient is really wanting that, saying, I want to be glasses free, just tell them that this will be, the risk is that it may not happen, but the risk is that we're going to be opening Pandora's box, and then it's going to be a nightmare. And yeah, I have an ascertainment bias, which is that's the only time I see problems, but those patients are so problematic that it's often not solved by just strabismus surgery or prism. Often we have to do, optical rescue, which means putting them into an optical correction that corrects their monovision. You can tell how unhappy the patient is about doing that. And then what happens is that I would say the majority of them can't stand that, so they may do it for a while, but then they just stop wearing those glasses because they go back, and then you're like constantly fighting this fusion breaking, and then their strabismus problem recurs, and then you're kind of going around in cycles. And then, yeah, you could theoretically do an IOL exchange and then abandon monovision, but that's a fairly major thing to do, which you could have avoided if you'd had just gone for 20/20 vision, both eyes simultaneously in the distance. So for those of you who are anterior segment surgeons, I would leave that with you. Yeah.
So what about a patient who is actively doing monovision and they have strabismus? Because sometimes I'll run into those, and I never do monovision in a strabismic or even intermittent, all those things. But and I actually, won't do a multifocal either. But a mono, like if they're already enjoying their monovision and suppressing, and when I make them fuse, they have trouble. Like
Yeah.
make them have the same.
Yeah, no, right. It's a great question. Yeah, so the question is, how long have they been in that state? How happy are they? And do they have any other symptoms, right? And do they have any desire? Because some of them will start articulating, a desire for better binocularity. So you have to kind of drill down into what are we as a bigger team, which can be the anterior seg surgeon and the strab team all together, or some people do it both. What are we trying? What's the end game here? What are we shooting for? If the end game is essentially duplicating what I have with clearer vision, then that's the one exception, and you've brought it up, where it's a reasonable thing to do. Because the flip side is that if you want to go the other route, then you have to do some pre-op testing, which is a contact lens or glasses to undo the monovision, and then see how they readapt, and then even see how they readapt with the angle corrected. And so it's a series of either glasses and or contact lens and or Fresnel prism, and it depends on how big the angle is, whether that's feasible. So, and then you come back to, well, what are we trying to achieve here? And so it goes back to one of my earlier comments, which is that the patient is always right, which is that let's talk about what we're trying to achieve. So, the patient who goes into cataract surgery with a desire to be glasses free, really it's what was your starting point, where are we going to? So in summary, that would be the one exception that is, and you'd already figured it out because so thanks for sharing the case, because I think that's good for the whole audience. Thanks. Yes? Do you have issues with multifocals? I do. Because of the lack of contrast and the fact that, and again, I have ascertainment bias, which means the only multifocal people I tend to see are patients who come in with problems. So for me, to be as fair as possible, I would say the jury is still out. I think that the rubber meets the road for me when there's a multifocal in a patient who has a history of strabismus, because now you're potentially adding other hurdles to fusion that might not have been there if you'd have just put in a straight monofocal lens. So that would be my concern. Yeah. Yeah, so I think that, from sort of first principles, the answer is it may. And so then it comes down to, how risk averse is the patient and how risk averse is the surgeon. So to play it safe, the problem with intermittent exotropia is it's one of the diseases that keeps on giving for your lifetime. And it's, I call it the inexorable exotropic drift. They will just keep on going. Yeah. My bias is that we're better to play it safe. And then it comes down to the patient desire versus patient need. You might get a fireman or an EMT who has professional scuba diver who really wants the ability to function at multiple distances, and that's really high on their list of priorities, versus the average patient who is a little bit of an inconvenience to pull out their reading glasses, but if you can give them 20/20 uncorrected vision in the distance, you're doing them a really big favor. So and again, it comes from the bias of the sorts of problems that I see. To be entirely fair, someone should do that study, and then we don't have the data on it right now. So in other words, to give the patient the risk profile, right, is what is the percentage chance that you're going to be an unhappy patient at the end of the day? But having seen some unhappy patients that way, making fusion harder is something that I would recommend against.
Sorry, we're going to have to wrap up this session, but we would love to take it outside.
Yeah.
Jonathan Holmes will be available to talk
I
a little
will.
bit. But we do have a lunch at 12:30 down in the hallway ballroom. But thank you so much again, Jonathan.
Thanks.